So I think I'll move on to the next session. The next session is by Dr. Harsha Sagar on management of acute heart failure. Dr. M. Har yeah, Dr. M. Harsha Sagar has done his MD General Medicine from Kasturba Medical College, Mangalore, and DM Cardiology from Kasturba Medical College, Manipal. He is a recipient of gold medal in DM Cardiology. Dr. Late Arun Guzgal Award in DM Cardiology, gold medal. Best outgoing student in DM Cardiology. Dr. KP Ganesan, Dr. BM Hegde, and Dr. Prabhakar Rao silver medal in MD General Medicine, and the best outgoing student in MD General Medicine. He has a lot of interest in academics and publication, and there's a lot of publications to his name. I think without taking much time, I hand over the session to Dr. Harsha.
Thank you, sir. I'll start sharing my screen.
I think Dr. Raghavendra, if you can just exit. Yeah, thank you.
So is my screen visible?
Yes, it's visible. Yeah, you can proceed.
Okay. Good evening, everybody. Today I'll be discussing about management of acute heart failure. I've divided the topic into 8 subtopics. First, I'll be talking about introduction. Then I'll be talking about classification of heart failure. Then we'll discuss about clinical presentations of acute heart failure, a small note on investigations and treatment. And finally, we'll discuss about the recommendations for the treatment of heart failure. So coming to the introduction, so what is acute heart failure? It is nothing but rapid or gradual onset of symptoms and signs of heart failure. So that will make the patient seek medical attention. So either he may come for admission or he may come to the emergency. So this is the addition in 2021 guidelines. Even a visit to the emergency is considered as an acute heart failure presentation. It doesn't require admission, even a visit is considered. Acute heart failure has become the leading cause of hospitalization, especially in patients above 65 years, and it is associated with high mortality. The mortality can range up to 10% in some patients. Post-discharge, 1-year mortality can be up to 25 to 30%. So that is why it is a very important topic. Before I jump into the management part, let us just understand the classification. Based on the LV ejection fraction, the heart failure can be divided as HFrEF, that is heart failure with reduced ejection fraction, when LVEF is less than or equal to 40%. HFpEF, that is heart failure with preserved ejection fraction, when the LV function is more than 50%. If the LV function is between 41 to 49%, we call it heart failure with mildly reduced ejection fraction. This was according to the ESC classification, that is European Society of Cardiology. The American Cardiology Society classifies heart failure into 4 stages, that is stage A, B, C, and D. Now, what is stage A? So patients in stage A, they do not have any symptoms. So no symptoms, and they do not have any structural abnormality in the heart, but they have risk factors. What are the risk factors? They can have hypertension, diabetes, obesity, or any genetic predisposition for cardiomyopathy. Coming to stage B, this is the pre-heart failure stage, wherein patients do not have symptoms, but they have one of the following. That is, either they have structurally abnormal heart, they have elevated filling pressures on echo, or they can have elevated natriuretic peptides, that is NT-proBNP, or elevated troponin. Stage C, these patients are the symptomatic heart failure patients. These patients actually have symptoms and signs of heart failure. Coming to stage D, this is the advanced heart failure group, wherein patients have marked symptoms in spite of GDMT, that is goal-directed medical therapy. Now, another way to classify heart failure is based on clinical examination. You just have to look at 2 things. That is, whether the patient is having any congestion or if the patient is having hyperperfusion. Congestion means the patient is edematous or the patient is breathless. So, because of LV dysfunction, the patient can have pulmonary congestion because of fluid accumulation in the lung, or patient can have orthopnea or PND. Now, because of RV dysfunction, patient can have peripheral edema, elevated JVP, congested hepatomegaly, or a positive hepatojugular reflex. So we have to look at the patient, examine him, and see if he's congested or not. The second thing is you have to see if the patient is having adequate perfusion. If the patient is having hypoperfusion, that means there's decreased blood supply because of hypotension, he'll have a cold and sweaty extremities. If you examine, his peripheries will be cold, his pulse will be feeble, and because of decreased perfusion to the brain, he can have mental confusion and dizziness, and also decreased urine output. So after assessing the congestion status and the hyperperfusion status, we can divide him into 4 categories. So the first category is where the patient is warm. That means his perfusion is good and there is no congestion in his lung. So he's dry. We call this warm and dry. If the patient perfusion is good, but his lungs are congested, we call it warm and wet. Similarly, if the patient's perfusion is reduced, he will be cold, but there is no congestion. So this we call it as cold and dry. And looking at this final subset, here the patient is having poor perfusion, so he'll be cold, and his lung is fully edematous, so he'll be wet. So this is cold and wet. Usually these subset of patients are very sick. So just by looking at the patient and examining, we can divide the patient on clinical basis. Now let us discuss about acute heart failure. I'll just be focusing on acute heart failure because of shortage of time. I won't be going to details of chronic heart failure. If you see acute heart failure, there are 4 presentations which are commonly noted. So the first is the acute decompensated heart failure. The second common presentation is the acute pulmonary edema. The third, a little uncommon, is isolated right ventricular failure. And 4 is cardiogenic shock. So now let us try to understand the differences between each entity because the management is different for each subset of patients. Now let us see the ADHF patients. Now these patients have acute decompensation because of LV dysfunction. The LV, that is the pump, is not working. So he'll have sodium and water retention. Because of this, the fluid is accumulated, and this is accumulated in the lung, or it can be accumulated in the periphery. Now, this usually develops over a few days and the patient gradually worsens. If you check the hemodynamics, his LV filling pressures will be elevated and his pulmonary capillary wedge pressures will be elevated. These patients can have low BP and also have a low cardiac output because of the failing pump. Now, when you examine him, because the patient is having a failing heart, he will be congested. So he'll be wet and there can be decreased perfusion in the periphery. So he can be cold. Now, how do we treat it? It is very simple. Since the patient is congested, you have to give him some diuretics to remove the excess fluid. And since the patient is having poor perfusion, start him on inotropic support or vasopressors. In spite of this, if the patient does not improve, then you have to consider mechanical circulatory support, that is MCS. So that is about acute decompensated heart failure. Now let us look at the second subset of patients, which is acute pulmonary edema group. Here, the main problem is because of fluid redistribution. Here, the fluid has accumulated in the lung because of an elevated afterload. In simple words, the patient will have high BP, uncontrolled BP, hypertensive emergency, and there is accumulation of fluid in the lung. This happens rapidly, and that is why these patients come to us with flash pulmonary edema. If you look into the hemodynamics, the patient will have an elevated LV end diastolic pressure and an elevated capillary pulmonary wedge pressure. But his cardiac output is normal and his BP is high. These patients have a normal LV, but an elevated BP resulting in pulmonary congestion. If you examine him, there is pulmonary congestion, so the patient will be wet, but the periphery is warm because of good BP. In order to relieve his congestion, we have to start this patient on diuretics. And to decrease the BP, you have to start this patient on vasodilators. So that is why understanding the subset of patient helps us in planning the management. Now, coming to the isolated right ventricular failure group, this is not a very common presentation, but we do see it. So here, these patients have only RV dysfunction. The LV is normal. This is again can be gradual or rapid in onset. Because the RV is dysfunctional, his central venous pressures are elevated. And also, there'll be systemic hyperperfusion because the RV forward output is less. If you check the hemodynamic, his RV EDP is reduced and his cardiac output and BP are reduced. Since his perfusion is poor, this patient will be cold. And since RV is failing, this patient will be wet. So how do we treat him? So we have to treat him with diuretics to relieve the congestion and inotropes to increase the perfusion. In case if the patient does not improve, then we have to put this patient on mechanical circulatory support. Now coming to patients with cardiogenic shock. So these patients are basically very unstable and high-risk patients. They have severe cardiac dysfunction. As the name suggests, this patient is in shock. There is no perfusion at all. His BP is low, his cardiac output is low. If you examine this patient, because of low perfusion, he'll be cold and he'll be congested because of failing LV. Now, the main thing that you need to do in these patients is improve the perfusion. How do you do that? You improve the perfusion by starting this patient on inotropic agents or vasopressors. Once the perfusion pressures improve, you can introduce diuretics to relieve the congestion. If the patient deteriorates, then we have to consider mechanical circulatory support. So this is again the same slide. So what you need to understand is it always will not be a separate presentation, but it can be a mixture because there is always an overlap. You can see that acute decompensated heart failure patients will have symptoms of LV failure and symptoms of RV failure. Symptoms of LV failure include orthopnea, tachypnea, and pulmonary congestion. Symptoms of RV failure include peripheral edema, elevated JVP, hepatomegaly, and positive hepatojugular reflex. Now, so this is a mixture of subset. So acute pulmonary edema patients will have an increased respiratory rate, use of accessory muscles for respiration. They will have hypoxia. If you do the ABG, his partial pressure of oxygen will be less than 60. His PaCO2 pressures will be more than 45. And the PaO2 by FiO2 ratio will be less than 300. So these patients can also have some features of LV failure. And similarly, patients with right ventricular failure, they also have some common entity with the acute decompensated heart failure. And if the perfusion pressures are reduced, ultimately all these patients will land up in cardiogenic shock. So it is basically a mixture of these presentations. Now, this is the SKY classification for cardiogenic shock. I won't be going into details, but everybody should go through it. Coming to the investigations. Suppose you get a patient to the emergency and you're suspecting heart failure, how do you investigate? The first and the foremost is to take proper history and examine the patient, look for the signs of heart failure. This is the first step. The second step is to do relevant investigations. So let us see what are the relevant investigations and how do we take history and look for signs. So what are the common symptoms of heart failure? You need to remember that symptoms can be because of congestion, that is because of fluid accumulation, or because of reduced cardiac output, that is nothing but hypotension. Now, again, congestion can be on the left side or on the right side. If the congestion is because of LV failure, they will have symptoms such as dyspnea, PND, or orthopnea. If the symptoms is because of RV failure, they will have an elevated JVP, they can have pedal edema, they can have early satiety or anorexia because of gut edema, abdominal bloating, weight gain because of peripheral edema, and nausea. So these are the symptoms of congestion. Now let us look at the symptoms of hypoperfusion or because of hypotension. So here the patients will be feeling very weak, they'll have fatigue, generalized weakness, early satiety, they're not able to do even simple activities, exercise intolerance, poor concentration, unexplained weight loss, malaise. So these are the common symptoms which a patient with orthopnea will give you. Now, after that, the next thing is examination. So how will you examine this patient? Start head-to-toe examination. Look at the skin color. So look for any cyanosis. If there is any cyanosis, that will give you a clue that this patient is having hypoxia, probably because of pulmonary congestion. If there is cyanosis, it also tells you about low cardiac output and peripheral vasoconstriction. A pale skin will tell you that this patient is anemic. And if the patient has jaundice, probably this patient has liver dysfunction because of right heart failure. Look at this nails, the second step. If there is clubbing, that means there is chronic hypoxemia and this patient probably has chronic heart failure. If there is any difficulty in breathing, it indicates that there is shortness of breath and that is because of pulmonary congestion. Assess the patient's nutritional status. If there is evidence of cachexia, that means the patient is in end-stage heart failure. So just by head-to-toe examination, you'll get so much information about the patient's status. Now, what are the investigations that you need to do when you have a patient suspected of heart failure? I'll just highlight the important points. First, do an ECG. Why? Because you need to look for any arrhythmias or any ischemia, because this can be treated. Then get a chest X-ray. Look for any congestion in the lung. Followed by a lung ultrasound, again to look for any curly lines and look for congestion. Echo is a very important modality that will give us so much information about the LV function and also about mechanical causes. Among blood tests, the most important blood test you need to do is NT-proBNP, that is natriuretic peptide, brain natriuretic peptide. So if the brain natriuretic NT-proBNP is negative, it has a high negative predictive value. That means if the value is normal, it is unlikely that the patient has heart failure. Whereas a positive NT-proBNP may not always mean the patient is having heart failure. It has a high negative predictive value, just remember. Troponin to again look for any myocardial injury or ischemia. Serum creatinine to assess for renal function. A small note on NT-proBNP. NT-proBNP, if it is less than 300, it will exclude heart failure. If it is more than 300, heart failure is confirmed. There are certain conditions where NT-proBNP can actually be lower. And in certain conditions, it can be elevated because of other than cardiac reasons. What are the conditions where NT-proBNP can be lower? In patients who are obese and also in flash pulmonary edema patients, NT-proBNP can be falsely low. What are the conditions where NT-proBNP can be falsely elevated? You have cardiovascular causes and you have non-cardiovascular causes. There's a lot of list in this. Just remember the important ones. That is acute coronary syndrome, pulmonary embolism, myocarditis. Also atrial and ventricular arrhythmias, pericardial diseases, invasive surgical procedures. So in these conditions, NT-proBNP can be falsely elevated. The patient may not be having heart failure, but his NT-proBNP can be elevated. Other non-cardiovascular causes include advanced stage, kidney disease, liver disease, anemia, sepsis, or stroke. Again, a summary of the same thing that I told. As soon as the patient comes, look for symptoms. Look if the patient is congested. Look if there's any hyperperfusion. Then check his vitals. That will help you decide if the patient is unstable or stable. If the patient is stable, immediately do an echo, do POCUS, treat the precipitating cause, and you give the specific treatment. If the patient is stable, then you send for NT-proBNP testing. If NT-proBNP testing comes negative, heart failure is ruled out. If the NT-proBNP is positive, that means heart failure is confirmed. Further, you proceed with ECG, chest X-ray, and echo. Confirm the heart failure. Look at the type of heart failure. I already discussed the 4 phenotypes of heart failure. That is acute decompensated heart failure, acute pulmonary edema, isolated RV failure, and cardiogenic shock. Based on that, you have to consider treatment. So that is about investigations. Now that you've established the diagnosis of heart failure, the second step is to look for the precipitating cause. Before you look into the precipitating cause, you have to rule out 2 important things. That is cardiogenic shock and respiratory failure. If you think the patient is in cardiogenic shock, you have to start him on inotropes immediately, or you have to put him on mechanical circulatory support. If the patient is in respiratory failure, think about intubating the patient and putting him on ventilatory support. If the patient is not having cardiogenic shock or respiratory failure, then start to look for the precipitating cause. So that is to look for what is the reason why the patient became unstable. Why is he having heart failure? There's a small mnemonic for that. It's called CHAMP-IT. C stands for coronary syndrome, H is hypertension, A is arrhythmia, M is mechanical causes, P is pulmonary embolism, I is infections, and T is tamponade. You need to look at these causes because these causes need specific treatment. If you have excluded all this, then you can manage only the heart failure. Now coming to the actual treatment of heart failure. So how do you manage this? Now again, I will discuss in 4 subgroups or 4 separate patients here. The first is, like I discussed earlier, the acute decompensated heart failure. So this group is ADHF. Now here, you know, this patient has a lot of fluid accumulation. There is congestion and fluid overload. So after that, you see if the patient is having hyperperfusion or not. Suppose the patient is having normal BP, his extremity is warm. So this will be wet and warm side. Suppose this side. Suppose the patient is having good perfusion, but he's congested. To relieve the congestion, you have to start him on diuretics. And usually we prefer loop diuretics like furosemide. Once the congestion is relieved, then you can start him on other heart failure medications. Suppose the patient is still having symptoms of congestion, then you have to increase his diuretics, or you can combine with other group of diuretics like thiazide diuretics or acetazolamide. In spite of that, if the patient is having any diuretic resistance and is going to renal failure, you have to consider renal replacement therapy. So this is the wet and warm category. Now here, look at the right side. So here the patient is congested, so he is wet, plus patient is having hyperperfusion. So he is cold. So how do you manage these set of patients? You have to start these patients on inotropes because the patient is having poor perfusion. And since he is wet, start these patients on diuretics. So it's a combination of diuretics plus inotropes in this subset of patients. So again, reassess for hypoperfusion and congestion. If the patient improves, then you have to put him on medical therapy. Suppose the patient deteriorates and his BP starts to drop, then you have to add vasopressors to increase his BP like norepinephrine or noradrenaline. If the patient continues to deteriorate, has hypotension or hypoperfusion or organ damage, then you have to put this patient on mechanical circulatory support plus minus renal replacement therapy. So this is how you manage the first subset of patients, that is acute decompensated heart failure patients. Now let us look at the second group, that is the acute pulmonary edema group. Suppose the patient comes to you, you find that this patient is having pulmonary congestion, there is bilateral crepitations on auscultation, and you know that patient is in pulmonary edema. So first thing, start this patient on oxygen, or you can put this patient on non-invasive ventilation, that is your BiPAP or CPAP. If the patient tolerates, well and good, otherwise you should be ready to intubate and put the patient on ventilator support. That is the first thing, airway. Now, second thing, look at his perfusion pressures by checking his BP. Suppose his BP is normal. So here the BP is normal. So the patient is wet, is congested, and his BP is normal. So he is wet and warm. If the BP is normal, so you have to start this patient on loop diuretics to relieve his congestion. So start him on Lasix to relieve the congestion. And since the BP is elevated or BP slightly on the higher side, you can put this patient on vasodilators to reduce the BP. So that will relieve the congestion. If the patient improves, just optimize his medical therapy. If the patient worsens, you have to consider mechanical circulatory support. Now, suppose the BP is low, the patient is having hyperperfusion. In such cases, you have to start this patient on loop diuretics plus inotropes because the patient's BP is low to relieve the congestion. So here, the patient is wet plus he is cold because his BP is low. In simple words, when the patient is wet and warm, just diuretics is enough. If the patient is wet and cold, you have to give inotropic support plus diuretics. Now let us look at the third subset of patient, that is the patients with isolated right ventricular failure. So first thing is you have to rule out two important entities. One is ACS, that is acute coronary syndrome. Patient can have RVMI or acute pulmonary embolism. If the patient has RVMI or acute pulmonary embolism, you treat it accordingly. Once you have ruled it out, then you know that it's not MI, it is not pulmonary embolism, it is purely isolated right ventricular failure. The first thing that you need to do is optimize his fluid status. So before that, see if the patient is congested. If the patient is congested, that is patient is wet, then you have to start this patient on diuretics. If there is no congestion, patient is dry, then you have to give fluids because RV dysfunction responds to fluids. Then followed by looking at his hypoperfusion and hypotension. If the patient has any hypotension, then you have to start this patient on vasopressors. If the patient has no hypotension and still the patient continues to worsen, then you have to consider RV assist devices or renal replacement therapy. Now coming to the last subset, this is the fourth one, that is cardiogenic shock. Here the patients are sick. These patients are having congestion, plus they'll have hypotension. First thing again, rule out any acute coronary syndrome or mechanical complication. If there is any acute coronary syndrome like MI or mechanical complication, send him for immediate PCI or surgical repair. Once these two things are ruled out, then comes the heart failure management. So look into the specific causes of heart failure precipitating factors and treat it. After that, what are the things that you need to do? First, start the patient on oxygen because the patient is congested, his lung is full of fluid, he's having hypoxia. So give oxygen or NIV, or you have to intubate the patient. Now, to correct his hypotension, you have to start him on inotropic support or vasopressors. And if the patient deteriorates, you might have to consider mechanical circulatory support. If the patient improves with these above measures, then you have to find the etiology and treat it. If the patient continues to deteriorate in spite of inotropic support and vasopressors, you have to consider mechanical circulatory support and renal replacement therapy. So again, this is again a summary. If the patient is wet, if the patient is warm and dry, so here the patient is quite stable, there's no congestion and there's good perfusion. You just have to treat the comorbidities and optimize his medical therapy. Suppose the patient is having good perfusion, but he's congested. So here you have to consider diuretics and vasodilators to decrease the BP. Suppose the patient is cold, that is, he's having poor perfusion, but his lungs are clear. In such case, especially in this RVMI patients, you have to give fluid challenge and you can consider inotropic support. In patients with cardiogenic shock, where is congested plus he's cold because of hypoperfusion, you have to start him on inotropic support, vasopressors, and once the BP picks up, consider adding diuretics. And if the patient worsens in spite of this, you have to add mechanical circulatory support. So this slide, if you remember, you'll be able to manage all the subsets of patients who present to you with acute heart failure. And a small note on the recommendations by the European Society of Guidelines. The first thing is about oxygen and ventilator. When should you give oxygen? You should give oxygen when the saturation is less than 90, or on ABG, if the partial pressure of oxygen is less than 60. If the patient continues to deteriorate, then you have to consider intubation. When do you consider non-invasive positive pressure ventilation, that is your CPAP or BiPAP? So here, if the respiratory rate is more than 25 and if saturation is more than 90, you have to consider non-invasive positive pressure ventilation. Coming to the recommendation on diuretics. So intravenous loop diuretics are the first line of recommendation. That is your Lasix or furosemide. That is to relieve fluid overload symptoms. Suppose the patient is not responding to loop diuretics, you can always add a second diuretic, that is thiazide. But you have to be careful because the combination can result in complications like renal failure and electrolyte abnormalities. Now coming to recommendations on vasodilators. I told you that in patients with acute pulmonary edema with high BP, the aim is to reduce the BP, so we have to give vasodilators. Just remember, two commonly used vasodilators in our clinical settings is nitroglycerin and nitroprusside. So you might have seen, we might be telling to start the patient NTG infusion. So you start at a dose of 10 to 20 mics per minute and you can titrate up to 200. Just be watchful, some patients can have hypotension and headache. These are the common side effects. Nitroprusside, the starting dose is 0.3 mics per kg per minute, and you can increase up to 5 mics per kg per minute. Again, the side effect is hypotension. Some patients may land up with cyanide toxicity. Remember, it is light sensitive, so you have to cover it while administering it to the patient. Coming to inotropes and vasopressors, what is the recommendation? Which inotrope to use and which vasopressors to use? And when do you use inotropes? You have to start inotropes if the BP is less than 90 by 90 mmHg, and that is class 2B recommendation. And routine inotropic agent is not recommended unless there is symptomatic hypotension. No need to start the patient on inotropes. Vasopressors is to increase the BP, and most commonly used vasopressor is norepinephrine. That is class 2B recommendation. Now, a small note on the different inotropes and vasopressors. You can see the commonly used inotropes is dobutamine and dopamine. Both are beta agonist. You just have to remember the important doses. Dobutamine is 2 to 20 mics, and dopamine, the dose that is required is around 5 mics. If you go beyond 5 mics, it can cause vasoconstriction. That effect we do not want. The other drug that we use is levosimendan. This is a calcium sensitizer, and this usually has to be given as a bolus dose, followed by an infusion of 0.1 mics per kg per minute. And norepinephrine is a vasopressor. It also has a beta agonist, and we start at an infusion of 0.2 to 1 mics per kg. There is other drugs. These are nothing but phosphodiesterase inhibitors like milrinone and inoxaparin, which we commonly do not use. Coming to the mechanical circulatory support. So what are the recommendations? You need to put the patient on mechanical circulatory support when the patient is having cardiogenic shock, and that is basically a bridge to recovery or bridge to decision. Suppose the patient is planned for cardiac transplant, you want to keep the patient alive till the transplant is done, then you have to put this patient on mechanical circulatory support. In MCS, again, there's so many devices, I will not be able to go into the detail. Now, coming to IABP, this is intra-aortic balloon pump. That is also recommended in patients with cardiogenic shock, especially has bridge to recovery or bridge to decision. So till the patient decides or till the patient recovers, we have to put him on some mechanical circulatory support. A small note on the guideline-directed medical therapy. So after you stabilize the patient with acute heart failure, you have to optimize his medications for his heart failure. There, we usually give 4 drugs. That is A, B, C, D. These are the 4 pillars of heart failure management. So any patient with LV dysfunction or HFrEF, you need to start this patients on AC inhibitors or ARB or ARNI. So that is A. ARNI is sacubitril valsartan, AC inhibitors, and ARB. Also, you know, it can be enalapril, or it can be ramipril, or it can be telmisartan and other drugs. The second drug, B, stands for beta blockers. So you have to put these patients on beta blockers. The drugs which we commonly use is metoprolol or carvedilol. And C is basically nothing but actually S. It is spironolactone or aldactone. And D is dapagliflozin, that is your SGLT2 inhibitors. These 4 are the pillars of heart failure management. And diuretics according to the patient need. So once you start the patient on these drugs, you have to reassess the patient, see if the patient is improving. If the patient is improving, continue this GDMT, that is goal-directed medical therapy, guideline-directed medical therapy. If the patient continues to have the EF less than 40, then you need to assess his symptoms. If it is a patient is an African American, you can consider hydralazine plus nitrate. That's nothing but isolazine. And if the patient has EF less than 35 and has a higher survival of more than 1 year, you can consider ICD, which is an implantable cardioverter defibrillator. If the patient has symptoms and he falls into NYHA class 2 to 3, he has LBBB on his ECG, his QRS is more than 150 degree, and his EF is less than 30, then you have to consider this patient on CRT. In spite of this, if the patient continues to deteriorate, we call it as refractory heart failure. And this patient is suitable for cardiac transplant. Until he gets the transplant, you need to put this patient on mechanical circulatory support. So that is about the management of acute heart failure and then optimization of drugs for heart failure. Thank you.
Thank you, Dr. Harsha. Such a elaborate talk. I think I was just, I could not take my eyes off the screen and your words. It was such an elaborate talk. I think it was, we do not have at present any questions. I think if anything is there, Dr. Harsha, you can just answer it in the chat box.
Yes,
so,
sir.
as we are going little late, I think I'll take to the next session. I think I have the next session. I'll finish it faster so that Dr. Anjana can have her session on acute aortic dissection. I think any introduction is needed.
Yes.
Just can you shortly introduce? I'll just start.
Yes, sir. Just give me a second.
Yes, sir. Okay, good evening, sir. It's my privilege to introduce Dr. M. Sudhakar Rao, a consultant cardiologist at Manipal Hospitals, Bangalore, and associate professor at Kastuba Medical